Then our last speaker for this morning is Susan Sinclair, Managing Director of RM Partners, and Sadie Begum, Head of Informatics at RM Partners. And they're going to discuss how data can help us identify inequalities exist.
Thanks, everyone. Today's been a really, really insightful morning, and it's always a real pleasure to follow such impactful talks that are coming from the heart of what patients are experiencing with lots of data. But I hope what this will do is show how much the stories that you've heard this morning are really, really underpinned by the data that we see. Can I just ask a quick question? How many of you were taught to assess erythema by anything other than redness? One person. So, as Nalan says, the structural injustice within the health service actually is huge and goes all the way back to our training as nurses. I'm Susan, I'm the Managing Director of RM Partners, and I have with me Hope Sayaka-Lines, who is one of our information team within RM Partners. And Sadia, put your hands up. And Sadia and Hope have been absolutely instrumental in helping RM Partners Cancer Alliance become an Inequalities First organisation. Cancer Alliance's roles are really to improve early diagnosis through reduced inequality and early diagnosis. And of the two, we can probably make about a 7% win on early diagnosis just by reducing inequality. So if I was in NICE, I would basically be approving a drug on a 7% win. Yeah, so the most fundamental thing we can do is think about how to address inequalities to bring everyone up to the best areas in our patch. My background is nursing and haematological nursing, and I've been with RM Partners for about 4 years now. So we haven't talked a huge amount about deprivation today, but I think that it underpins everything we do. How many of you have heard of Core 20? Does anyone fancy giving an explanation? No. So Core 20 is a way of looking at our population and focusing resources on the 20% most deprived. But really importantly, it comes with a big plus. And the plus is areas or populations within your area, within your geography, that are particularly affected by inequality. So that will be for our populations very much people who are of colour and of people that are facing inequalities. Starting with deprivation, though, what you can see is this is a report that was actually issued in November 23, but you may have heard it being reported in the media this week. And what it shows is that people from the most that are experiencing the most financial pressure are probably double as likely to not seek help for healthcare for their health as those with less financial pressure. We also know that people in the most deprived areas are twice as likely to wait for over a year compared to those in the least deprived areas. And I've been at conferences in the last couple of years where they've shown that things like the independent sector, which was supposed to really help reduce waiting lists for everyone, in fact only advantaged the least deprived. So it created a wider inequality, and for that reason some people have pulled back from it. So I think it's important to remember that in the crisis that we hear about every week, and many of us, I think, have probably experienced to some extent in our lives, the cost of living is having a profound effect on people's ability to manage their health. Early stage cancer is the aim for us in terms of focusing on the easiest way to save lives. So we know that if we diagnose people early, it's much less morbidity of treatment and much more likely to have 5-year survival. And this data is looking at the likelihood of being diagnosed early, i.e. stages 1 or 2, by deprivation, and this is in RMP. So RMP covers from Hillingdon to Croydon, so northwest London and southwest London. And what you can see is that in the least, this is the average, And what you can see is in the least deprived areas, you are much more likely than average to be diagnosed with stage 1 or 2 cancer, about 2 to 3%. Whereas in the most deprived areas, you are 4.5% less likely to be diagnosed early. And the difference between the richest and poorest is 6.1%. We've heard a little bit about intersectionality today, and what we've got on this table is the difference by our populations, and apologies for using such crude terminology to describe huge variation in populations. But what you can see is that we have, for the least deprived groups to the most deprived in that population, fairly significant differences. So 6.9% variation between the Asian population, depending on whether they are from a less deprived or more deprived area in terms of their likelihood of being diagnosed early, 10.7% for black people and 4.2% for white. We also, in RMP, have looked at each of our boroughs to see where early stage diagnosis is most and least likely. And Brent, in northwest London, has our lowest early stage diagnosis, with 10% difference between there and Sutton. What you can see in the middle is that that's effectively telling you their ranking, with 14 being the least early stage diagnosis. And given the impact of deprivation, we've then looked at whether that correlates to the deprivation of that borough. So what you can see is that for Brent and Ealing, there's a really high correlation between the deprivation and the likelihood of early stage diagnosis. But it is complex. It doesn't fully describe what's going on. So Hounslow is our third most deprived borough, and actually also has very good early stage diagnosis. So it doesn't explain everything. Just in terms of incidence rates of cancers, we wanted to show what's happening by ethnicity by comparing the likelihood of the overall cancer rate, so this isn't by stage of diagnosis, by the population within RM partners, by that ethnicity. And what you can see is that for white people, while they have the highest rate of cancer overall, actually the incidence is fairly static. So this is looking between 2018 and 2022. You'll see we've basically just ignored the COVID year because we had bizarre numbers coming through, about 1,000 less cancers presented that year. For Asian people, there is a significant increase year on year, and in fact, over between 2018 and 22, it's a 30% increase in cancer incidence in RM partners. And for black people, again, fairly high increases and virtually the same rates of cancer as in the white population. In terms of then thinking about what tumours people are getting, you can see that for all ethnicities, the top 5 rates of tumour specialties are the same, with the exception that in the Asian population, there is far less lung cancer, which means that for Asian people, head and neck is a more prevalent cancer than in the top 5. So I'm going to hand over to Hope to talk through the patient experience information now to help show what's happening to people through their diagnosis and treatment. And this is based on the NC-PES survey. Have all of you heard of NC-PES? Yeah? Great.
Perfect. Great. Thank you, Susan. So one data source that we can use to identify potential inequalities is the National Patient Experience Survey, so NC-PES. This is an annual survey that's run by NHS England, and it covers all parts of the patient's cancer pathway, from primary care, seeing your GP, through to treatment, and living with and beyond cancer. So the data that I'll present is from the 2022 survey, and it's looking at the national results due to low response rates for some of the subgroups. But these findings are actually indicative of what is going on more locally as well. So we've just picked out a few key questions here. So the graph on the left, this question is relating to primary care, and if the patient saw their GP within 3 months of first thinking that something may be wrong with them. The black line at 0% represents the national average, And then the coloured bars indicate how much the results for the different subgroups are above or below this average. So we can see that ethnicity, which are the teal-coloured bars there, play a significant factor. So black patients actually reported waiting more than 3 months, the highest levels of waiting more than 3 months until first seeing their GP. And that was 11% more than those reported by patients of a white ethnicity. Also, gender played a significant role. So the bars at the bottom, 7% more males reported waiting more than 3 months. And this also correlates with the tumour type table that you can see on the right there, with prostate cancer at the lowest and breast at the highest. So this next question is again around primary care, but this is about the number of times that a patient saw a healthcare professional prior to their diagnosis. And again, ethnicity played a significant factor, so those teal-coloured bars on the graph on the left-hand side there, with Asian, black and mixed-race patients reporting the highest levels of seeing a healthcare professional 3 or more times, and that was 10% higher than the national average. Also, there's a more detailed breakdown of the ethnicity on the graph on the right. So the teal colour shows seeing a healthcare professional 3 or 4 times, and then the purple bar is if they saw a primary care professional 5 or more times. And we can see that Asian patients, so the second from the top, reported the highest proportions of going to a healthcare professional 5 or more times. That was 12%, and that was double what we saw in white patients at 6%. So this next question is around the treatment explanation, so more secondary care. So it's looking at if the treatment options were explained to a patient in a way that they could completely understand. You can see that age played a significant factor here, so the blue-coloured bars in the graph, with the youngest age groups reporting the lowest levels of having their treatment options explained. And that was 7% lower than the national average. And then we also have treatment involvement, so whether the patients were being involved as much as they wanted to be in decisions about their treatment. And again, age was a significant factor here. So the youngest age groups reported the lowest levels, which was 10% lower than the national average, and also sexual orientation. So those patients who identified as LGBTQ+ reported the lowest levels of being involved as much as they wanted, and that was 4% lower than the national average. Finally, we have a question about respect and dignity, and this is whether the patient was always treated with respect and dignity whilst they were in hospital. And we can see here that, again, age was a significant factor, the youngest age groups reporting the lowest levels, and also gender. So females reported the lowest levels of being treated with respect and dignity, and that was 4% lower than what was reported by males. So I will hand you back now to Susan.
Thank you. So that was a real canter through some huge amounts of data there. Question for you. How many of you are shocked by that data? Yeah? Can anyone articulate what's the most shocking or surprising thing?
I think it's the extent to which that's present in all categories.
Yeah. And as a nurse, when I first saw this data, I found it really difficult to reconcile it with my nursing practice, because I think we go into nursing and we nurse thinking that we're helping people. And I think it's really, really important that we understand this is systemic. And that shouldn't make us paralysed. It should make us hold some power, because we are the biggest workforce in the whole NHS. And nobody has a bigger role in advocating for patients than nurses. So if I look back at my training, I did a whole course on haemoglobinopathies, which I am proud I can pronounce. And the people that get haemoglobinopathies, the sickle cell and thalassemia, are people of African origin and people from Cyprus and Turkey. And I don't think I had a single mention of racism. this is, we're all doing jolly well. But actually, we know in London people with sickle cell, young people have died in the last couple of years. And we know it's in maternity, and I think certainly for cancer, we want it to be different in cancer, but it will only be different in cancer if we take the experiences that Stuart and Sharon have reported, look at this data, and start thinking about how we can act differently. So we've also got the World Cafe. And just before we step down, is there any other questions that anyone wanted to ask this morning about the data? We're sort of conscious that we've gone through loads.
We have got time for Q&A.
Yeah, I fought hard to get Q&A.
I've got one to get things started. I was interested about you look at when you were ranking the areas, and what do you think Hounslow is doing differently? That they're getting the lower stages of cancer.
So the model that Stuart presented at the beginning is a really good way of thinking about it, and it's sort of very similar to the WHO way that people get diagnosed with cancer. So the first thing is you have to be aware of symptoms. And you have to be able to come forward with those symptoms. And I think when we talk, we hear a lot, like in COVID, people don't trust the health service. But when you look at this data, it's really not very surprising they don't, is it? That seems to me to be the most evidence-based approach to sort of not doing something where you're not going to be treated nicely. So I think there's, for those populations, I think there's, first of all, are we making sure that people really understand that the screening tests are for them? And so, for instance, we know, and we keep hearing whenever we go to some of these conferences, that cervical smear tests are very, very difficult for young Asian women to go to. It's culturally really, really difficult. And so self-swabbing is likely to be a really big win on that. So, and we also hear of other examples where allowing sex workers, for instance, to put the speculum in themselves for a cervical smear allows them to maintain control. And Stuart talked earlier about trans experiences of cervical smears. So there's something about we've got to make sure that people feel that they are included in screening. But I would remind you that 94% of cancers are diagnosed outside screening programmes. So as well as that, we have to make sure that, one, we are arming communities with the information and about the fact they too may get cancer and what to look for. And we have to support them, I think probably in a fairly advocacy way, to be able to get help with their GP in a way that redresses some of this. And I think it's a really complex situation, isn't it? Because when I had terrible preeclampsia and they decided to do a caesarean, if you'd said to me, by the way, you're probably going to face some discrimination, so don't forget to advocate for yourself. I actually didn't really care whether I lived or died at that moment. But the thought that I would have to have advocated for myself would have been impossible. So we've also got to stop expecting communities to sort out the problems the system is creating for us. The second bit is about the experience in primary care. And I think, like most of the NHS, I mean, how long ago were you really aware of systemic inequality? For some of you, it might be today. But how many of you have ever had formal training on anti-racism or systemic inequality? Okay, so it's less than probably 3% of this room. So primary care, which is far more diverse in terms of tiny organisations caring for patients, I think there's something about making sure that they're aware, because people, in all of this is not about individuals treating people badly. It may be, but actually the wider problem is the system. So we have to all understand the system so that we can all put our shoulders to supporting it. We also know in primary care that there are some wins around decision support, and that certainly would help remove variability in referral practice. Looking externally, so using external audits. And I think really sharing case studies and being open. So we have many more opportunities than primary care to share and work as peer review. And I think the other thing that we definitely know is an issue, and, I think is interesting because Hounslow's got West Mid, which is a very, very kind of strong community hospital, is that the level of trust between secondary care and primary care really counts for some of this. So there's some of the things that we think are fairly impactful. So next year in Brent and Croydon, which is the area with the least early diagnosis, we're working very hard on the patient experience, patient interval and referral interval, so we can get people coming forward quickly and know that they're going to be treated. Because irrespective of how many times you think it is appropriate for a patient to be seen by a GP before they get referred, you don't want to have variation. Yeah, it should be the same for everyone.
Just thinking that if we knew what they were doing, as you said, we can model it in other areas like Brent.
We've spent a long time looking, and I think what I think about some of this is you have to sort of just embrace the marginal gain strategy and break down these issues. And I think in the NHS we tend to just create a box and expect everyone to go through it, and it's serving less and less people.
Adding what Susanne just said is absolutely fantastic, and you're absolutely right. And I think the other thing I'll add is just using grassroots organizations, really going down to the communities and actually utilizing what works for them. And I think often we've felt like we have to do unto people, and that doesn't work. It's actually getting the people involved and then utilizing that resources that they already have because they know that. And I've also spoken somewhere where I mentioned about the medium through which we communicate with the communities. We often do a lot of grand national campaigns, and people don't actually watch those channels that are being used or those media avenues that are being used. And actually, there are specific media within the communities that are more accessible to people. So, local radios, local TV channels, where those populations are more in tune to tune in and watch, and utilizing that would be really, really useful way of then getting the message out there. And also maybe something about screening, where people often feel that it's meant to diagnose cancers, which is not the intention because we're screening healthy populations. So it's turning that messaging on its head and actually encouraging people to go that, it's not particularly meant to diagnose cancers, but it's also to check, and if there is something, then that will be picked up early. So it's about the messaging through which we utilize, and that will also engage people with the process. Thank you.
So it's just to add to what has been said. In around Kingston area, we started assessing the migrant group, and we are invited to give a talk. And you will be very surprised. Majority of the people have not heard of cervical screening. And the more people we reach out to, the more we get new diagnoses. So there are a lot of those medias around us if we can try to reach out to them. Thank you.
Thank you.
Thank you for those 2 points. I think they're absolutely correct, and certainly RM Partners, our primary care team, did a huge piece of work with North West London ICS on really engaging with grassroots organisations about things that are preventing people coming forward for screening. And I think exactly what you said is right.